بسم الله الرحمن الرحيم. ده presentation برضه مبني على المبدأ بتاع الbrainstorming أو العصف الذهني لتسهيل توضيح الداتا ليكم وعشان تعرفوا النقط اللي فيها دايمًا مشاكل بالنسبة لكم في الstudy بتاعكم. أنا دكتور حاتم أمين خطاب، استشاري أول طب وجراحة العين بكلية الطب جامعة الزقازيق. بنقول دايمًا ما عندناش أي تعارض بين إن إحنا نفهم المنهج بتاعنا وإن إحنا ناخد الfull mark وإن إحنا في نفس الوقت نستمتع بالstudy بتاعتنا. النهارده الpresentation بتاعنا عن الكورنيا، كورنيا interactive، يعني الداتا بتاعت الأمراض قرنية العين بصورة تفاعلية. نبدأ.
A systematic approach to executing the slit lamp exam will help you effectively evaluate your patient's eyes. Before performing your slit lamp exam, first complete an external inspection of your patient, looking for any abnormalities of the external
I'm going
eye.
to bring the slit lamp in front of you now. Okay. And if you could just place your chin there, perfect, and forehead to the front.
Appropriately adjust the slit lamp or chair for both you and your patient. Unlock and turn on the slit lamp.
I'll start with an inspection of your right eye.
In ophthalmology, the convention is to examine the right eye first.
Just look at my right ear, please.
Begin by first examining the upper lid and lashes. Start at the medial canthus and work your way slowly across the lid to the lateral canthus. Here you are looking for any lesions such as a chalazion or lash abnormalities such as collarettes or trichiasis. Then move your light to the lower eyelid and perform the same examination on the lower lid. Move your examination to the inferior fornix, where you'll examine the palpebral and bulbar conjunctiva. Place your finger gently on the lower eyelid to retract the eyelid,
I'm just going to place my finger on your lower lid. Could you look up for me, please?
allowing yourself a full view of the palpebral and bulbar conjunctiva. Then move your examination to the superior bulbar conjunctiva and sclera. To examine the superior palpebral conjunctiva, evert the patient's lid. Next, you will examine the cornea. Initially, it's helpful to have the light directly illuminating the cornea and span the corneal width. To view all three layers of the cornea, epithelium, stroma, and endothelium, place the mirror slightly to the side and keep your slit beam narrow. This will give you a light reflection on the cornea in the shape of a long 3D rectangle. The most anterior reflection is the epithelium. The stroma is in the middle, and the most posterior reflection is the endothelium. In cases of trauma or different disease states, it's important to be able to describe which layer is affected. Continue to move your examination in the direction of more posterior structures. The next structure is the anterior chamber. Here you can look for a hyphema, which is a layering of red blood cells, or a hypopion, which is a layering of white blood cells. In order to assess for cells in the anterior chamber, turn your light to a very narrow and short beam, so it looks like a small square. Then increase your magnification and increase your light strength. If you toggle your focus between the surface of the cornea and the iris, you'll find yourself focused on the space between this, the anterior chamber. If there are cells present, they will appear like dust floating in a movie projector beam. Again, moving to more posterior structures, the iris is next. Here you can look for any masses, iris muscle tears in trauma, or abnormal blood vessels as in diabetes. The lens is the next posterior structure. Observe for any opacity here. While it is easier to see past the lens into the vitreous with a dilated pupil, in a dark room and medium light, you will be able to see vitreous veils if you move your mirror slightly oblique.
Okay. And that's our examination.
You're now equipped with a systematic approach to executing the slit lamp examination.
Let us start our quiz. First case, a 34-year-old gentleman. He came complaining of ocular irritation after common cold for 5 days. He went to a nearby pharmacy and was given this drug by the pharmacist. The condition deteriorated. He asked for ophthalmic care. The ophthalmologist found this appearance on the slit lamp. What is your diagnosis? This is a typical dendritic corneal ulcer stained with Rosenberg. The name comes from its resemblance to the dendrites of a tree, like this actor and his son. Regarding the treatment needed, we give antiviral drug. It is due to herpes simplex, like ganciclovir or acyclovir, plus the usual treatment of corneal ulcers. If there is a relation between the drug used and deterioration of symptoms, of course, yes. Steroids enhance the growth and replication of this virus, the herpes simplex virus. If there is a unique treatment for this lesion, especially if resistant, yes, debridemol, it removes the virus-infected cells and minimizes the antigenic stimulus for many immune complications of this virus infection. Specific complications sometimes encountered in such cases is geographical or hemophoid ulcer, especially if given immunosuppressives or the immunity is compromised. It's called geographical, like a map, or amoeboid, like amoeba. This test would reveal corneal hypothesia. The second case, a 23-year-old lady had a history of use of either glasses or contact lenses to correct simple myopia. She went for a safari in Kenya. Her glasses were broken. Unluckily, in the meantime, she ran out of her disinfecting solution of the contact lenses. She had an overnight wear of her contact lenses for 48 hours. Acutely, she developed severe headache, severe ocular pain, lacrimation, photophobia, blepharospasm, and misty vision. She asked for ophthalmic care. This was the appearance on the slit lamp. We have many questions. What is the diagnosis? Microbial keratitis with hypopyon. We have corneal symptoms. We have corneal infiltrate. We have positive fluorescein staining. We have ciliary injection. And we have hypopyon. Just to remember, if there is a relation between contact lenses and the pathology, of course, yes, soft contact lens wearers have a tenfold increased liability to get corneal infections than non-wearers. This may be due to The trauma of insertion or removal may be due to contamination of the contact lens disinfecting solution or the lens cases, may be due to corneal hypoxia. Could this drug be used to reduce intraocular pressure in such a case? Never ever use pilocarpine. In such cases, pilocarpine produces spasm of the constrictor and ciliary muscles and increases the pain and may be complicated with iritis. Such cases, we use cycloplegics like atropine. It is unlogic to go forward and backward in the meantime, meaning it is unlogic to use a mydriatic and cycloplegic in the meantime in the same case. What to do? We should have a stepwise approach to manage such cases. First and most important is hospital admission. Immediately, we do corneal scraping. Corneal scraping is done to obtain a material for the microbiology lab. This material is sent to the microbiology lab for culture and sensitivity tests, for bacteria and fungi, also for staining with gram stain and other microbiological non-stains. The incriminated microorganisms may be bacteria, may be fungi, and may be acanthamoeba. If you suspect a fungal etiology, would you wait the results of culture and sensitivity? Of course, no. Fungal culture may take up to 3 weeks. We start our treatment immediately after sending the material obtained by the scrap to the microbiology lab according to our clinical suspicion. What if the results of culture and sensitivity tests stated that your prescribed antimicrobial was ineffective? This depends on the clinical response. If the patient's course was favorable, the pain was decreasing, the infiltration was decreasing, the vision was improving, I will continue my treatment. On the other hand, if the response was unfavorable, I will change the antimicrobial treatment according to the report of the microbiology lab. The third case, a 44-year-old gentleman, something hit his eye during passing in his car. Suddenly, he felt severe ocular pain, spasm, lacrimation. 2 days later, he had blurred vision, severe ocular headache. He went to the ophthalmologist on the slit lamp. The ophthalmologist noticed this appearance. Later on, the condition progressed into disappearance. More and more, the condition deteriorated more and more. Combining these photographs, this is the appearance. What is your diagnosis? This is a case of fungal corneal ulcer or keratoconus. This is because of the typical history of blunt trauma. They infiltrate with feathery margins, elevated edges, rough texture, satellite lesions, hypopyon, and endothelial plaque. The leaves of this plant are very sharp. The field is very crowded. The leaves produce a double effect. They interrupt the intact corneal epithelial barrier, and in the meantime, they provide the infecting fungus.
This video is a little dark, but what we have here is a central corneal ulcer, and down below you can see a small hypopyon. Now this ended up being a fungal ulcer. It was difficult to treat. It was slowly reactive to amphotericin. It was also difficult to diagnose. With these fungal infections, it's quite deep in the cornea. You really have to get a deep specimen to grow out anything. Now as you can see here in the slit beam, there's some minimal thinning, perhaps feathery margins to the edge of this thing, maybe a satellite lesion, but in reality it's almost impossible to distinguish a fungal ulcer from a bacterial one, short of actually culturing it.
Which is unfound or unlogic in previous patient. Of course, the unlogic is conjunctival injection. This patient has ciliary injection. All other choices are correct. Which is untrue concerning managing the previous patient. Of course, the answer is domiciliary treatment. These cases are emergencies and are treated at hospital. All other choices are correct. Unfortunately, this patient required penetrating keratoplasty. Fourth case, you were asked by a pediatric resident to evaluate the eyes of a child in the malnutrition unit. The pediatrician stated that his eyes looked abnormal. This is the malnutrition unit. This is the severely malnourished child. The ophthalmologist used a portable slit lamp. This was the appearance of the right eye, and this is the appearance of the left eye. Which is false concerning previous patient. This is a case of keratomalacia. Perforation is very common, and total ankylocyanici are very common. All other choices are correct. Just remember the appearance in cases of keratomalacia. Very liable to get perforation. The fifth case, a 40-year-old lady, a soft contact lens user. She used her contact lenses during diving. Acutely, she developed severe ocular pain, blepharospasm. This was the appearance on the slit lamp. These are the epithelial changes on the slit lamp. The epithelial changes on the slit lamp with progression, stromal manifestations also appeared. This is the progression of the stromal changes. Extensive ossification and hypopium formation. This is a typical history in cases of acanthamoebal keratitis. The patient usually has very severe pain out of proportion to the clinical signs due to the perineural infiltration. This is the typical organism. It is called the great muscurator. It can be easily misdiagnosed as viral keratitis, as bacterial keratitis, as fungal keratitis. We give anti-amoebic medications plus the usual treatment of corneal ulcer. The sixth case, an 18-year-old gentleman. He had a blurred vision and asked for glasses. He noted the need to change the glasses prescription repeatedly in the last 14 months. He had a history of intense ocular itching of 10 years duration. On ophthalmic examination, this is a slit lamp used for anterior as well as posterior segment examination. We can detect markedly increased corneal curvature, also markedly increased corneal curvature, also scissoring red reflex. This is a similar case, markedly increased corneal curvature, markedly increased corneal curvature with angulation of the lower lid margin on looking downwards. This is called Manson sign. On averting the upper eyelid, we noticed giant pupillary conjunctivitis or GPC. This is a case of keratoconus plus spring catarrh. Keratoconus is a common complication of spring catarrh, may occur in up to 27% of cases. The main complication is acute corneal edema or corneal hydrops. How to manage such a case? Regarding the optical problems of keratoconus, we start in a stepwise manner. First, we use glasses. We may resort to hard contact lenses to flatten the cornea and improve the refraction. In many cases, we resort to collagen cross-linkage to increase the percentage of crossed links in the cornea to make the cornea more stiff and resist progression of the pathology. In advanced cases, we use intracorneal ring segment insertion inside the cornea. This increases the regularity of the cornea and improves the quality of vision. As a last resort, in advanced cases, especially if there is a corneal hydrops, we may resort to penetrating keratoplasty. Plus the usual medical treatment of spring catarrh. Concerning this patient, all is true except the lesion is characteristically painless. Intraocular pressure is expected to be above 30 mm mercury. Conjunctival injection is diagnostic. Fluorescein may occur. Of course, the characteristic feature in these cases is ciliary injection, and the lesion is painful. As concerns this young man, which would be true? This is a case of advanced keratoconus as evidenced by positive Manson sign. The refraction is typically myopic due to increased curvature of the cornea. The refractive error is so difficult to be corrected with soft contact lenses. We use hard contact lenses to flatten the cornea. All of the following may be used in the treatment of this condition. All these photographs delineate this metocele, very eminent perforation. We are trying to minimize perforation by reducing the intraocular pressure through carbonic anhydrase inhibitors, absolute bed rest, anterior chamber paracentesis, bilateral ocular bandage to minimize movement. We give antibiotics. Of course, pilocarpine is wrong. Pilocarpine is contraindicated to minimize the intraocular pressure in any case of corneal ulcer. In these patients, all is correct except LASIK is the preferred technique to correct his myopic astigmatism. Anterior chamber depth is increased. Penetrating keratoplasty may be needed. Hard contact lenses may be of help. Corneal thickness is decreased. This is an example of advanced keratoconus. These cases has myopia and has astigmatism. Of course, LASIK is absolutely contraindicated. These cases have low corneal thickness. LASIK further decreases the corneal thickness. If I used LASIK, I would increase his refractive error rather than correct his refractive problem. The causative organism of these corneal lesions, of course, herpes simplex virus. The most probable intraocular pressure value in this patient is 30 millimeter mercury. This is the case of hypopion, corneal ulcer. Viscosity of the anterior chamber is increased due to the presence of the hypopion and the plasmoid aqueous. Facility of aqueous outflow is much decreased. Consequently, the most logic number would be the last choice. This 67 years old man had undergone a nice cataract surgery. The second morning, he complained of severe ocular headache and marked diminution of vision. He had all except ciliary injection, hypopion, yellow fundus reflex, secondary glaucoma, and xerosis. This is an example of acute post-operative endophthalmitis following cataract surgery. All the choices are correct except xerosis. Regarding the sign in the corneal periphery, all is true except common in 20s, composed mainly of lipids. Visual acuity is markedly affected. Panas is a differential diagnosis. This lesion is common in the elderly. If it is encountered in the young, we should suspect hyperlipidemia. Visual acuity is unaffected due to its presence in the periphery rather than the center. This is the arcus senilis. In these patients, all is true except pneumococci can give this typical appearance. Severe pain is characteristic. Classically treated at home, conjunctival injection is the route. This is a case of open corneal ulcer. It is an emergency treated at hospital, and ciliary injection is the rule. Which is false as concerns this patient. Anterior chamber paracentesis is the main treatment. Microbiological study is a must. Hospital admission is strongly indicated. There is typical ciliary injection. Atropine sulfate is required for treatment. All choices are correct except the first one. Anterior chamber paracentesis has no role in such a case. It is used only if there is desmatocele and eminent perforation. Which drug would be incriminated in the progression of the corneal lesion from the form on the left to the form on the right side? Of course, this would be a steroid like dexamethasone. This is a geographical corneal ulcer stained with rose bengal. This ulcer is stained with, of course, both fluorescein and rose bengal, what is called double stain. The drug that caused this ulcer to progress to such a size would be, of course, betamethasone. Surgery performed for this patient is penetrating keratoplasty. These corneal lesions are preferably not treated with prednisolone will aggravate the condition. Ciprofloxacin has no therapeutic effect. It is a viral ulcer. It concerns this boy who had undergone an ocular trauma, which is false. The central fluorescein stained corneal ulcer has prognostically bad corneal vascularization. A second corneal ciliary injection has good healing potential, marked diminution of vision. Of course, the second choice is the answer. Corneal vascularization is good prognostic factor for healing. It means that the ulcer has entered into the stage of healing. The material used for staining this epithelial defect is fluorescein sodium. The lesion in the upper cornea is an active vannus. Commonest organism to cause these unrelated conditions is, of course, pneumococci. The left photograph delineates a case of typical hypopian corneal ulcer. The right one, a case of acute bacteriocystitis. The surgery may be used to treat all except uncomplicated phyllectanular keratoconjunctivitis. Phyllectanular keratoconjunctivitis has a dramatic response to corticosteroids. All other indications may be used in penetrating keratoplasty. Which is untrue concerning this patient. Severe pain and photophobia are typical. Conjunctival injection is evident. Hyphema is characteristic. Secondary glaucoma is expected. Pilocarpine is ideal anti-glaucoma drug. Of course, this patient has ciliary injection as hypopion rather than hyphema. Of course, pilocarpine is absolutely contraindicated as an anti-glaucomatous drug in such case. The surgical technique illustrated is indicated in treating primary angle closure glaucoma, diffuse central corneal opacities, hypermature senile cataract, macular hole, flood staining of the cornea. Of course, it is used in diffuse central corneal opacities and neglected flood staining of the cornea. This technique is helpful for testing corneal sensation. Concerning corneal thickness, this lady has a central corneal thinning. This is an example of congenitally myelinated corneal nerves. This is a positive sidal test. We resort to this test if we have a thin cornea, like dermatocele or like a penetrating trauma, to know if the ocular surface is completely open or partially open. This is called sidal test or river green test. Another example of sidal positive test. The aqueous humor comes out from the eye stained with the fluorescein. Central corneal edema, acute corneal edema and keratoconus, what's called hydrops, diffuse central corneal edema, diffuse central corneal edema, diffuse central corneal edema, arcus senilis, hypopion corneal ulcer, hypopion corneal ulcer, most probably fungal, perforated corneal ulcer with iris prolapse, glaucoma adherent, glaucoma adherent, glaucoma adherent, total anterior staphyloma, total anterior staphyloma. For contact, this is my phone number. This is the WhatsApp group. This is the student page on the Facebook. This is the YouTube channel. This is my team. Thank you and have a nice day.